The following content is provided under a Creative Commons license. Your support will help MIT OpenCourseWare continue to offer high-quality educational resources for free. To make a donation or view additional materials from hundreds of MIT courses, visit MIT OpenCourseWare at ocw.mit.edu.
So welcome to the third class of the Health Information Systems to improve quality of care in resource-poor settings. 2 weeks ago, you heard Dr. Zoya Mukherjee set the stage and describe the backdrop into which we would like to introduce these information systems. And she pointed out nicely that we can't do this without tying it to development programs. We can't do this without somehow transforming the infrastructure to maximize the benefit of these systems. And then last week we heard Dr. Hamish Fraser convincing us that it is possible to provide care to complex medical conditions such as multi-drug resistant tuberculosis as well as HIV. But this also required some information system to facilitate the healthcare delivery. We're gonna change gear for a little bit and focus now on quality improvement. And I'm gonna start off by relating a personal story. So this was back in 2002, July 31st was the date. I was mountain biking and sustained a lower leg fracture. I went to the hospital and the orthopedic surgeon, the bone doctor, assured me that this is a simple procedure. I will be back running marathons again before I know it. So the surgery was scheduled on a Friday afternoon in July. And as you know, July is when the house staff turns over. There are new interns, new residents. And then I didn't know too that that night that I had my surgery, all the nurses working on the orthopedic floor were all agency nurses. So they don't usually work there. So as you could see, those are all the Swiss cheese holes lining up for a major catastrophe. So I finished the surgery at about 5 o'clock, and then at 1 a.m. I was awakened by this pain over my leg. So I called the nurse, and they thought that it was just pain over the incision site. They gave me some morphine. An hour later, the pain was actually getting worse, and I had requested them to call the orthopedic resident, the junior doctor in orthopedics, who happened to be in surgery involved with another operation. So he ordered the nurse to give me more morphine. And that happened every hour, and the pain wasn't going away. So at about 7 o'clock in the morning, I was getting so frustrated, I actually called my boss, who was the head of the ICU at Johns Hopkins. I begged him to get me transferred to another hospital. He made some phone calls, and within 15 minutes, the consultant, the attending who was taking care of me was there. He was actually scolding me, why didn't you call me directly? And I didn't want any special privileges. Like, I wanted to go through the right channels. Like, just because I'm a doctor, I don't expect some entitlements. But anyway, it turned out that I had what we call compartment syndrome. It's when the swelling after surgery got so severe that it cut off the blood supply to the leg. And that is one of the feared complications after a bone operation. They should have been on top of this complication, but it took about 5-6 hours before they picked it up. By the time I went to surgery, I've lost the muscle in the lateral compartment of my leg, so they had to remove all the dead muscle. There was still too much swelling, so they couldn't close it. It took another 5 surgeries to be able to fix my leg. Originally, the plan was 1 surgery. I picked up an infection in the hospital. I developed a bone infection from Pseudomonas, one of the nastiest organisms, and was on antibiotics for 4 months. And I'll show you my, so there's my leg. And that's pretty much my story. The caveat is that my caregivers were actually good people. I met the resident finally who showed up at the end of the day after my emergency fasciotomy, and he was the nicest guy. The nurses who took care of me were also hardworking nurses. They had no intentions to give me a compartment syndrome or surgical site infection, but the system was designed to give me these complications. So this past week, I've been on service in the intensive care unit. Every single day, one of my patients died in the intensive care unit, and they were in their 80s to 90-year-old. And if you've been in the ICU, it's not the best place to die. And the reason that that happened is that no one had talked to them about advanced directives when they were still healthy. Again, to me, this is a failure of the health system. And I read all your homework. I'm going to discuss some of the stories that you've shared with me. Thank you very much. So these are some of the assignments that were submitted. So a student at MIT developed a wrist fracture which was not followed up properly and led to reconstructive surgery due to missed non-healing. There was a catastrophic infection of the hip that was missed on a 15-year-old boy, leading to a delay in treatment. There was an arrogant pediatrician at Children's Hospital who dismissed the parents' concern about food allergy, and he had to be convinced to run some tests. And of course, the parents were right. A blood thinner was not started on a nursing home in Seattle because the facility forgot to get it approved by the primary caregiver, which was protocol in that hospital. A baby sister's brain injury was missed in Trinidad and Tobago. A patient died at MGH because a critical laboratory result was missed, and this incident is still haunting the doctor who was involved in the care. During surgery in Uganda, a sulfa antibiotic was given to a patient who was allergic to it, causing anaphylaxis. So anaphylaxis is a severe allergic reaction that could kill someone. Worse, the patient was charged extra for the additional hospital stay as a result of the complication, when in fact they should have known that this patient was allergic to that antibiotic. An elderly patient aspirated, so food went into the lungs during anesthesia in Cameroon because she did not understand the instructions not to eat before surgery. There was a grandfather who picked up a staphylococcal infection in a US hospital and died. A baby was given an adult dose of a malaria medication in Uganda, and she developed liver complications from the overdose and died. A mother-in-law in Mexico had advanced breast cancer missed, and even when it was discovered, the patient and the family were not informed of the diagnosis. A young healthy woman in Colombia developed a hospital-acquired infection and died. So as you can see, this is not limited to one part of the world. Medical errors abound everywhere. And I would like to quote Don Berwick, the director of Medicare Medicaid. And he says, every system is perfectly designed to achieve the results that it gets. So how do we define quality of care in medicine? So according to the Institute of Medicine, quality of care is a degree to which health services for individuals and populations increase the likelihood of desired health outcomes and are consistent with current professional knowledge. There are 6 components of quality of care. Can anyone give me some of those 6 components? Any takers? What are the main requirements for care to be of decent quality? David? Efficiency. So efficiency is 1. 5 more? Okay. These are the 6 worthy aims of healthcare. It has to be safe. It has to be effective. There has to be evidence with what you do. It has to be patient-centered. There has to be respect for the individual's values and choices. It has to be timely. There should be less waiting for both the patient as well as those who provide the care. And as David pointed out, it has to be efficient. There should not be a lot of waste involved with healthcare delivery. And lastly, and probably most importantly, it has to be equitable. There has to be no disparities in the provision of care, whether it's racial or urban-rural. In layman's terms, it means there should be no needless deaths, no needless pain or suffering, no unwanted waits, no helplessness, and no waste. This is some of the studies that have been done mostly in the developed world. Unfortunately, we don't have numbers from the developing countries. And the numbers in terms of the extent of medical injury per 100 hospital admissions range between 10 to 15%. And these are from chart reviews. Other people are saying that if you actually do observational studies, the numbers are going to be higher. In the United States, we have about 1.7 million hospital-acquired infections a year. And hospital-acquired infections, in addition to adverse drug events, are the two main components of medical injury. And the Institute of Medicine, as you know, had estimated anywhere between 48,000 to 99,000 preventable deaths as a result of being admitted to the hospital here in the United States. So this is the big paradox of healthcare. You have very well-trained doctors, nurses, pharmacists, physical therapists, and we know that they have altruistic motivations. And then we have all these advances in science and technology, but somehow we see all these shortfalls in quality. And some of you have seen this in the past, comparing healthcare with other dangerous industries such as the nuclear power plant, aviation industry. And as you could see in this graph, healthcare is on the left side, together with mountain climbing in terms of how dangerous it is. So when you get admitted, your chance of getting some injury is similar to mountain climbing. On the other side of the graph would be the ultra-safe industries. And you find there aviation industry, which has always been compared to healthcare, and the nuclear power plant industry. But people are always saying patients are not airplanes. Healthcare is much more complex than the aviation industry. For example, in healthcare, anesthesia is the safest of all the different specialties. We've reduced death to 1 per 200,000 cases, at least in the developed world. But even with those numbers, that is still 25 more times more dangerous than flying. People say, again, healthcare is complex. You have more than 155,000 possible diagnoses. You have more than 7,800 possible interventions. So it's difficult to do the right thing. But I could argue that industries of high intrinsic hazard, such as nuclear power plant, aviation industry, they're also very complicated, and yet they manage to be very safe. The main difference between healthcare and those other industries are in the organization and design of service. In healthcare, the delivery of service is organized around guilds. There are the doctors, the nurses, the pharmacies, and the different specialties. We have internal medicine, surgery, you have radiology. And design that we see now is a result of historical, political, and economic forces, not the analytical consideration of how to achieve the best results. On the other hand, other high-risk industries, they hire people who are focused on integrating new discoveries and disciplines into well-harmonized systems. They have distinct roles and for those whose responsibility is ensuring that pieces come together well. The same people would be rigorous in identifying when the design is inadequate. They're constantly looking out for unanticipated outcomes. They actually are excited when they see errors because errors is an opportunity to improve the design. So they detect errors and they convert them into expertise. And these are crucial to safe operations. In healthcare, quality, when it occurs, is due to the acts of mere heroism of doctors and nurses. We are expected to constantly make do and work around to get the job done. We fight the same battles every day, the same inefficiency, and achieve little headway in making things better. And to quote Albert Einstein, and I saw this as one of the status updates of one of the students, the definition of insanity is continuing to do the same thing over and over again and expecting a different result. So somehow we're miraculously expecting for things to get better without us doing much. So as I mentioned earlier, there are two major components of adverse events in healthcare: medication errors and hospital-acquired infections. So as regards hospital-acquired infections, 5 to 10% of patients would develop them when they get admitted. So they come in without those infections, they pick it up from either their carers or from the environment in the hospital. And we know too that the risks have steadily increased over the recent decades. And we also know that a significant fraction of these hospital-acquired infections occur in clusters or outbreaks, meaning there's definitely a link with people passing it on from one patient to another. Hospital-acquired infections are not unfortunate, inevitable consequences of medical procedures. Yes, David?
So those numbers are for the United States? Or?
Yes, those are for the United States. Unfortunately, as I said, no one has even started. There's a group in Latin America who started doing this, and we're hoping to bring them here in April to talk about adverse events in Latin America. And to quote myself, our processes are designed to infect the patients who develop hospital-acquired infections. How about adverse drug events? So adverse drug events are unanticipated injury resulting from medication intervention. A study that was performed here in Boston at the top Harvard hospitals found that there are 6.5 adverse drug events per 100 admissions. 30% of these are serious, 12% are life-threatening, 1% is fatal, and the biggest news is that almost half of them are actually preventable. How about in clinics, in ambulatory care? The numbers are roughly the same. 27 events per 100 patients seen in clinic. 13% of these adverse drug events are serious, and close to half of the serious adverse drug events were preventable. We knew them. We knew about the drug-drug interactions. We knew they were allergic to the medications, and still those medications were given to the patient. In the United States, there are about 8 million adverse drug events per year, and that's about 38 adverse drug events per provider per year on average. There are 3 million preventable adverse drug events, and 500,000 of those are life-threatening. In the last hour alone, there were 1,000 adverse drug events here in the United States, and 92 were hospitalized as a result of these adverse drug events. This is just showing you that money and resources are not the answer in terms of improving quality of healthcare. The United States actually leads the pack of developed countries in terms of preventable deaths in healthcare at the top of the list there, even though we spend the most money for healthcare. 16 to 17% of our GDP would go to healthcare. And people say that if the airline industry tolerated the error rate that we see in the healthcare industry, there would be 3 jumbo jet crashes every 2 days. But what I'm describing to you now is the tip of the iceberg. Most errors actually do no harm. They are never recorded, they are never documented. Most of them are intercepted. And also, you should consider the amazing ability of the body to heal and absorb the error. So for the most part, no one talks about the error. You don't disclose it to the patient. No one else hears about it. And we hope that it's forgotten over time. So why is preventable death so rampant in healthcare? These are some of the reasons why. One, there's a lack of awareness of the magnitude of the problem. But it doesn't seem so. Like, as I said, almost every one of you were able to submit to me a personal experience or someone that they know who had a medical error. These preventable deaths are perceived as unusual events or outliers. And most of the time, and I have been guilty of this in the past, poor outcomes from error have been blamed on complication of disease or inherent risk of the procedure. And a good example is hospital-acquired infection. We never tell the patient, I'm sorry, we gave you some infection from a resistant bacteria. We always say, oh, you were very sick, you had this procedure, that's why you picked up this infection. And that's, of course, a lie. Other things that contribute to this particular problem is that the healthcare culture is not particularly conducive for error detection. In the healthcare field, mistakes are unacceptable. When a mistake happens, we think it's a failure of character. That doctor or that nurse wasn't careful enough, or that doctor or that nurse didn't try hard enough. We rely on individuals not to commit errors rather than assume that they will. We think that if we train them properly and if we motivate them, they will have no mistakes. And this need for infallibility creates a strong pressure to cover up mistakes. One other thing which was mentioned by one of you in the assignment, there is no support at all in place for clinicians who have committed errors. We sometimes hear about this in what we call mortality and morbidity meetings, where we talk about some adverse events. And there is some learning that occurs there, but that learning is limited to that room. It's limited to the individuals who were involved in that mistake. They're not shared to future doctors or nurses so that they don't repeat those mistakes. And even those individuals tend to repeat the mistakes 10 years down the line. So unless you have a system that would learn from these mistakes, we won't be able to prevent them from happening again. So these errors are repeated in other locations or later in time unless you capture it in a learning system. But as I have said earlier, medical errors are committed by competent caring people doing what other competent caring people would do. Quality problems occur not because of a failure of goodwill, knowledge, effort, or resources devoted to healthcare, but because of fundamental shortcomings in the ways care is organized. How have we approached quality of care in the last century? So last century, as doctors, we did whatever we wanted to do in medicine. Most of the time, your practice is based on anecdotal experience, and as a result, there is substantial variations in the way we deliver care. If you have some urinary tract infection before, you go to 5 different doctors, they will give you 5 different opinions or 5 different antibiotics. The other thing too is one learns of new findings through conferences. There is no systematic way of translating what we call evidence-based medicine into practice. There were few guidelines and protocols in the 20th century. There's no routine measurement of processes and outcomes, and there's no individual feedback for the performance. Worse, there is no benefit for better performance, and sometimes we even incentivize poor performance. So if you remember one of the stories where that patient got an antibiotic that he was allergic to, he ended up staying longer in the hospital, and he was charged more for staying in the hospital longer because of a mistake that was done. And the same is true in healthcare, in a system where you have fee-for-service, where you could charge for every diagnostic test, for every procedure. If you develop a complication, they would have to do more tests, they would have to do more procedure, and they charge the patient those procedures and tests, even though the mistake was committed by the people who were caring for that patient. And there's also little information available to the public of which hospital had the best quality. These are some of the barriers to quality improvement. And we see this not just in developed countries, but this is also common in the developing world. You see old-style, control-oriented management. The management team is focused more on finance and revenue rather than on improving operational processes. There is a strong sense of professional hierarchy and entitlement. And there's also a lack of integration of the healthcare system with what is available in the community. Over this semester, you're going to hear different quality improvement approaches. You're going to hear about checklists. You're going to hear about the Lean or the Toyota production system as applied to healthcare. You will hear about positive deviance. You will hear about Six Sigma. And you will hear about the Plan, Do, Study, Act cycle from the Institute for Healthcare Improvement. But for today's purpose, I'm just going to show you 3 slides on checklists, which I find is probably the simplest and the cheapest quality improvement approach. And let me direct you to this book by Atul Gawande. 2 of his team members are going to be here in April to talk about their projects of how to use checklists to improve healthcare in Africa. So checklists, as you know, reduce the variability and standardize the work process. It democratizes knowledge. So now the same knowledge is available not just to the doctors, but also to the nurses and other members of the team. The best thing about checklists is that they actually summarize evidence into explicit behaviors. Most of you have heard about this landmark study by Miller in 1956, where he showed that humans can only retrieve 7 ± 2 pieces of information from memory with relative accuracy. So we can't really expect doctors and nurses to be multitasking and being involved with very complex tasks all at once after a 16-hour shift or after a 30-hour shift. So the memory, we know, increasingly becomes unreliable with complex procedures, stress, and fatigue. And it also significantly decreases in accuracy and speed when you're managing 3 or more tasks simultaneously, which is not uncommon among nurses and doctors and pharmacists and other people who work in the healthcare industry. So one of the checklist example or project that I would like to discuss briefly is a project to reduce what we call central line associated bloodstream infection. So central line is a tubing that is inserted into a large catheter so that if a patient needs a very critical medication, you're assured that it's going to go directly into the vessel and it won't be displaced from a small vessel. So we do a lot of this, especially in the intensive care unit. And in the 20th century, we see a lot of infected central lines leading to bloodstream infection. And of all the different hospital-acquired infections, this is the deadliest. This is the one that kills the most patients. What they found is that few things could actually completely eliminate central line infection. So this was a study that was started by Peter Pronovost at Johns Hopkins Hospital, and he came up with a protocol where he asked people who were going to place the central lines to wash your hands. Again, very simple, but not very well done in the hospital. Sterilize the procedure, put drapes over the patient before you put it, use a cap, mask, and sterile gown when you're going to insert one, use sterile gloves, and put a sterile dressing over the central line. And what they did too for this project is that they had a massive educational campaign. They put together a cart where it has all the things that you need before you insert the central line. So the cap and the mask and the gowns are there. So you can't say that, oh, I forgot to put them on because I didn't know where they were. They put a checklist in the cart. These are the things that you need to do. Make sure that you have this before you insert the central line. And every day, the nurses were empowered to ask, can we pull out the central line? And the nurses, too, during the procedure could say, stop. I saw this is not a sterile procedure anymore. We have to abandon this because there's a good chance that if you continue, the patient is going to develop a central line infection. And what they found was after they implemented the checklist, the central line infection was radically reduced to 0 at Johns Hopkins Hospital. So their next step was, can we do this at scale? Can we do this in a whole state? So they tried to introduce this to the whole state of Michigan in 2004 and recruited 68 hospitals to participate in this very simple quality improvement project. And what they found is that during the last 6 months of the study, there was not a single central line infection in the 68 hospitals who participated in the project. They had more than 1,500 patients deaths that were prevented. They averted more than 81,000 hospital stays with a cost reduction of $165 million. So the big question is quality improvement feasible in resource-poor settings? What are some of the problems that we see in the developing world? We know about lack of sufficient staff, absence of continuing education for the doctors, the nurses, and other ancillary staff. You have poor physical facilities. You have long distances between health centers. And there is also top-down management systems, not just in the developed world, but also in the developing country. And some of you would argue that it's even more common there. Like I practice medicine in the Philippines, and we have these legacies of colonialism. You cannot argue with the attending doctor. The consultant doctor is God. You don't say no to that. You can never question him. And the nurses are all fearful of the doctors. They cannot point out any mistakes. And I'm pretty sure that that's not a rare experience for the Philippines. I'm pretty sure that that's true. That's also common in New Zealand. And we used to see it here a lot too in the United States. I would argue to you that quality improvement is even more relevant in the developing world, because with quality improvement, you could optimize resource allocation and use. You could also provide donors the confidence in the ways in which their money is being spent. And you could argue that resources without improvement is only buying the same failed processes. There have been some examples of quality improvement in resource-poor settings that have been published. They have varying degrees of failures and success. I'm hoping that we would see more and more of these publications. There's not a whole lot out there, and hopefully you guys are going to be involved with some of these. For example, in Zambia, they tried to enforce a hospital accreditation council that would look at the quality of care in the different hospitals and would certify them as good enough to remain open, which reminds me of a story in the Philippines. So I'm getting sidetracked, but I have a friend who is a surgeon, and he saw this patient coming in with pain over the right upper quadrant of his abdomen, and she was a middle-aged woman, kind of fat, and the examination was very suggestive of infection of the gallbladder. And they told her that we think that this is a gallbladder infection, but the woman said, I had my gallbladder removed a couple of years ago, and she showed the scar. There's like a big scar there, which is typical of a gallbladder infection. And my friend wasn't convinced, so they sent her for an ultrasound, and the gallbladder was there. And upon investigation, it turned out that all they did in the other hospital was just to open her up and close her again and told her that her gallbladder has been removed and charged her for a gallbladder surgery. Again, that is an extreme case, but I could tell you those are not completely rare. Like, I've heard horror stories in New Zealand where it has something to do with accreditation of the providers. One person posed as an ENT surgeon when in fact he was a technician from the hospital he came from, and he was performing surgeries, and at one point he started suctioning the brain and the patient died in the operating room. So you need these accreditation boards to see what type of care is being provided, what type of people are being hired in these hospitals. And they tried this in Zambia from 1997 to 2000, and it wasn't a full success. What they found was the accreditation council was stymied by the lack of legal standing. The government was kind of indecisive on incentives and feedback. There was also lack of sufficient funds to continue this accreditation council. The people who worked there had a huge workload, and there was a difficulty in retaining the surveyors who were performing this accreditation. Moving on, there was a study in Ecuador measuring compliance with maternal and child care quality standards. And what they did for this particular quality improvement intervention is to introduce this intervention where they would do some educational campaign and then measure compliance with clinical standards. And they were also going to survey patients as regards their satisfaction and look at overall research utilization. What they found was even when there was improved compliance with clinical standards, there was no difference between the control and intervention group when it comes to client satisfaction as well as resource utilization. So they were a bit frustrated with the result of this particular intervention. This study was done in Zimbabwe, and they tried to measure the interaction, the relationship between the supervisors and the providers. So supervisors were district and municipal nursing officers who are responsible for guiding, assisting, and motivating the healthcare providers. And there were people who were observing these interactions. And what they found was that a lot of the supervisors were deficient in seeking input, problem solving, and building on previous visits. But there were some success stories. For example, they tried to introduce the WHO guidelines in managing childhood illnesses, IMCI guidelines in Niger. And they introduced a quality management to promote these guidelines, and also they measured some health program indicators. And what they found was the program was successful in Niger, and it was still successful 2 years down the line. There was continued practice of quality management by the healthcare providers. And one of the bigger success stories would be the Chilean Quality Assurance Program. The Ministry of Health there launched a nationwide quality assurance program 20 years ago. And in 1999, a team of international consultants in quality improvement went there, looked at 6 areas and 7 services, and what they found was They had good quality assurance program that was going on even 8 years later. So the program was successful in achieving sustainability and institutionalization. So one of the questions I gave to you for your homework is, how do you decide how much resources to allocate to quality improvement in resource-poor settings? And the answer, as you all expected, is going to be very complicated. But there are some guidelines. And one of the approaches that have been proposed by an ethicist named Norm Daniels is accountability of reasonableness. So these are not algorithms, these are not actual methods, but there are some rules in terms of how do you approach these questions. So accountability of reasonableness requires transparency in all the discussions. So everyone should know what's going on and how you allocate resources. All the stakeholders should be there. It shouldn't be just a few people deciding how much money should go into which projects. And it has to employ evidence-based approach to weighing the alternatives. It also mandates continuous monitoring and evaluation mechanisms to assess progress towards the set targets. And you're allowed to revise or stop an intervention if the expected gains are not realized. Your decision should be revisable in light of better evidence and argument. Obviously, there will be losers in rationing decisions. There will be people who will not get what they need, who will not get what they want. But what matters in accountability for reasonableness would be the grounds for establishing the priority and the methodologies used. Some of the methods that have been proposed include public hearings, testimonies from groups and individuals who are involved or who are going to be affected by those interventions, as well as formation of focus groups and other investigative approaches. So obviously, I don't have the entire hour to talk about this, but I would like to direct you to this book, Just Health by Norman Daniels, who talk about accountability for reasonableness. Is there a role that information systems can play in quality improvement? The main objective of why we need information system in quality improvement, there are actually several. The first is to link patient care with research and education. Medical literature doubles every 19 years. And to be able to practice medicine, you need to know at least 2 million facts. So it's really tough to expect your doctor to know all the new things, all the new evidence that comes up in the literature. Providers, on average, have one question for every 1 to 2 patients. And the average delay between evidence after it was published in a journal to practice change is about 5 years. So there's a big lag time, even after we've proven that one intervention is not effective and one intervention is actually beneficial to a certain disease. Information systems also provide the interface between different providers who are caring for the same patient. So it facilitates coordination of care, which is very important, especially when you're managing chronic diseases such as hypertension, diabetes, or HIV. Most importantly, information systems could standardize processes and could track clinical outcomes. There have been studies showing that information systems do benefit quality improvement. And one of the original papers was published by Chaudhry, who showed nicely that with information systems, there was an increased adherence to guideline-based care, enhanced surveillance and monitoring, as well as decreased medication errors. We also have a huge number of studies looking at the VA system. So the VA system is in charge of providing care to veterans here in the United States. And they were one of the front runners in terms of using electronic information systems, and very good evidence in terms of improving process and outcome metrics in the care of the patients, in diabetes, in preventive medicine, in hypertension. In chronic disease management, you could use information systems to support patient education, to improve management of results, especially the critically abnormal results, and it could facilitate population analysis and queries. This is a study that was published 4 years ago in JAMA, looking at the role of quality improvement, including information systems, in the care of diabetes. And although most of the projects did have some positive impact, the impact was very small. They're very modest as compared to the amount of resources that were put into those quality improvement projects. So the take-home point from that paper in JAMA is that most quality improvement strategies, including those involving information systems, produce small to modest improvements in glycemic control of patients with diabetes. And the main reason for that is you have to accompany information systems with infrastructural change, with cultural transformation. The facility, the groups of people who work in that facility should be working together and always thinking of continuous quality improvement. So there's a lot of organizational factors that affect the implementation of information systems. And this will be discussed by the speakers over the next 2 months. I would like to direct you to this book by Lorenzi and Riley, Managing Technological Change, Organizational Aspects of Health Informatics, if you're serious about going into this field. So let me summarize now. The challenges in quality improvement. The gains are slow, small, and usually not widespread. Sustaining systems redesign is always elusive. It's a tough, very challenging objective. System changes really need to be aligned across disciplines and multiple levels. You can't go to the Department of Medicine and say that you're going to have a quality improvement there. You can't go to the nurses and say that you're going to involve it in quality improvement, because the projects will need to involve different specialties and different disciplines to be working together to have the maximum impact of your project. You need to integrate redesign efforts with other system features, and this is where information technology can play a huge role. And most importantly, you have to align the incentives too. If you're not aligning incentives, if there is no incentive to improve care, then you're not going to achieve the objectives that you started. And it's working with people. You have to work with people well. You have to prepare and manage healthcare providers for change. You have to address issues on the confusion about role expectations. You have to address their discomfort with performance of new roles. You have to clarify the communication about who is accountable for the success of this particular project. And the main problem too is that most of the time you impose additional burden on staff who already have heavy workloads. So unless you completely redesign their workflow, it's not going to happen. Unless you make them more efficient, adding new tasks to them, it's not going to work. You're adding layers of complexity, and that's a recipe for even more errors. Sustaining and spreading redesign efforts are difficult to sustain. You have to really support this change, and you have to warn them ahead of time that there would be failures. You may not achieve your objectives right away. You have to anticipate disappointments and have a plan B. You need to engage the staff all the time, especially after the initial excitement has subsided. And most importantly, you don't incentivize doctors alone. You don't incentivize nurses. You incentivize whole teams so that the entire team will have a shared goal of improving the quality of the care they're delivering. So let's go back to that project that was started at Johns Hopkins and then went on to involve the entire state of Michigan. So the Department of Health and Human Services here in the United States went forward and said that we are calling for a 50% national reduction in central line infection over the next 3 years, and recruited all the more than 3,000 hospitals here in the United States. But up to this point, less than 20% of the hospitals have volunteered to participate in this project of the Department of Health and Human Services. And up to this point, most of those participating hospitals have not reduced their infection rate. So Peter Pronovost went back to the CEOs of those hospitals who were participating, and they said that we didn't see your good result because our patients are sicker than your patients at Johns Hopkins, which is quite hard to imagine. And that the infections that we see in our hospitals are inevitable, unlike your infections at Johns Hopkins. And we have competing priorities here. We have other things that we need resources for. So Peter Pronovost, in his editorial, said that if these lethal, expensive, and preventable infections are not a priority, what is? This is just a survey of how well hospitals here in the United States are implementing evidence-based medicine. So these are different projects. We have evidence how to reduce pneumonia that's acquired in the hospital. We have evidence on how to reduce surgical site infection, or SSI, which is what I had. We had evidence on influenza vaccination and how that decreases outbreaks in the hospitals. And of course, we have lots and lots of evidence with hand hygiene, having the providers wash their hands before they see the patient. And this is where we stand. They surveyed more than 1,200 hospitals, and the rate of implementation is anywhere between 30 to 35%. Yes?
I just wanted to go back to the last slide. Why did you go on after that? Why less than 20% of the hospitals in the United States, why is that they have not yet signed up for this? Because going from what you said, it's cost beneficial to hospitals to do this. So why is that less than 20% of the hospitals presently have not yet signed up for this process?
It's not completely true that it's cost beneficial. So the way we have it here is that you get paid according to DRG for your hospital stay. But the doctors are not part of that. The doctors' fees are different from the hospital fee. The doctors can charge every day that they see a patient. So there is someone who would benefit if you don't reduce the hospital-acquired infections. And a lot of them are just not aware that these central line infections are completely preventable. So there's no huge benefit. It's not like we're saying that if you participate in this program, we will give you $1 million. Clearly, we need to improve the incentive, the system for reimbursement, for example. So there have been changes. Don Berwick is completely overhauling Medicare as we speak. Now you can't charge for a central line infection anymore here in the United States. If they stay longer, the Medicare will not pay you more. You can't charge for additional consultation now. You get paid, again, as I said, according to DRG, which is the condition that you got admitted for. So there are things that you can do to actually push for quality of care. And unfortunately, that has not been the case in a fee-for-service system. And I know that in a lot of developing world, most of the care that's being given is still fee-for-service. So there's some incentive to order tests, to consult other specialties for a patient coming up with a simple problem, because you know that you could charge these patients more money. You're not paying for the outcome. You're not paying more money if you had a good outcome and less money if the patient dies. You pay every time a diagnostic test or an intervention is provided to the patient, which is a complete mistake. So Michael Porter is a big proponent of value-based healthcare system where you pay according to the quality of care that you get. So it's not really about reporting, protocols, checklists, and safe practices. It's about working together in a team, and the team has to be multidisciplinary, and there has to be mutual respect between the different groups. So the lessons learned from the Leapfrog survey, the lessons learned by Peter Pronovost in trying to scale this quality improvement project: old habits die hard, doctors and managers are still the problem, and safety and quality are less about practices than about relationships. There are 4 essential elements of quality improvement. First, policy. It must explicitly recognize the importance of quality as system goal and remove any disincentive to quality. Leadership. The management team should provide a vision and strategy to transition from the way we are working now to the way we want to work in the future. Number 3, you have to have the core values emphasizing teamwork and continuous quality improvement. And finally, there has to be resources allocated. There has to be delineation of responsibilities and accountability for oversight, coordination, implementation, and evaluation. And that involves 2 things. The first is capacity building. You have to train your staff with the necessary knowledge and skills to carry out their quality improvement responsibilities. And you need a good information system to measure processes and outcomes. So these are the revised rules for healthcare. Whereas before, doctor autonomy drives care variability, in the 21st century, care should be customized according to patient and his or her preferences. Whereas before, do no harm is an individual responsibility, in the 21st century, safety should be a system property. Whereas before, the system reacts to errors, in this century, errors should be anticipated. Whereas before, cost reduction is the goal, in the 21st century, waste should be continuously sought and eliminated. And finally, whereas before professional roles are emphasized, in this century, the focus should be working as a team. In simple language, set improvement goals, study the work process, design and test promising changes, measure, continuously build skills in system-mindedness, and finally, involve everyone. And to quote Lucian Lee, one of the grandfathers of quality improvement, teamwork is a secret of every industry that has succeeded in becoming safe. And finally, Maureen Bisognano, who is the CEO of the Institute for Healthcare Improvement, quality and safety are a multidisciplinary sport. And with that, I would entertain any questions.